Right, colleagues, good morning. Basically, the major report today is the standardisation of acute neuro-rehabilitation services. Now, there are many people whose names I'm afraid I don't know who's sitting behind me. And being a mere man, I can't remember all of them anyway, so Dan will introduce them as they come up. So, good morning, and I'm sorry that I can't see you all behind me.
Good morning.
Right. Do we have any apologies?
Yes, we do. We have apologies from Councillor Sophie Taylor and Anne Duffield from Trafford and Councillor Margaret Morris from Salford.
Thank you. Any declarations of interest? No.
I'll remember, my daughter's employed by Oldham Clinical Commissioning Group, so it's personal, no conflict.
Minutes of the last meeting. Have we any matters arising? I'm afraid I have, and it's directed to our colleague from NWAS. At the last meeting, the main reason we'd asked you to come in was to discuss DFIBs. You know, from the figures I'd already been given by your colleagues, I'm told that if you have a coronary incident out in the public area, you've got about 1 in 10 chance of surviving. But if there is a DFIB within 500 metres, that goes up to about 16%. So in other words, if we know where the DFIBs are, we've got 6 out of 100 people will live. Now, you guys are working on where you know DFIBs are. I wanted the members to help you get it more up to date, because I am quite honestly astounded at how many DFIBs are being purchased by community groups, which we're very grateful for, and we don't know where they're going. Now, we were promised that NWAS would send us like a pro forma chit, which in turn would be sent out through my colleagues to all of their councils. That way you'd have somewhere in the region of 600 councillors being your feet on the ground. I'm still waiting for that piece of paper. So that's my major thing. I felt it was something that was important. We are talking about a serious impact on people's lives. I don't know if you agree with me, but I do have concerns that we haven't had that paperwork.
Yeah, I was aware I think there are 3 kind of work streams that are looking at the same thing. There's from a city council perspective, I think GMFRS led and ourselves. I'll take that action away. I'll make sure you get the list of the location of all NWAS defibrillators. I wasn't aware that you hadn't received it. That'll be our community engagement team.
It wasn't a list of where the DFIBs are because the members can't do much with it. What we need to know is where the ones that you're not aware of. So we want a report from every council in Greater Manchester about ones in their wards. And rather than people just sending emails all over the place, we asked for a little type form that we could get them to fill in. Now, the second point, you can tell me the terminology, but you have teams in some areas which can respond very quickly. I forget what the name for these people.
First responder teams.
Thank you. And there weren't a lot in some areas of Greater Manchester. Now, I took that on board and I spoke to people in my borough, and I know for a fact a retired senior firefighter contacted NWAS on a couple of occasions and saying, look, I want to offer my services, I'm trained, but we don't seem to be having that continuity. I'm sorry to be critical, but there's very little point in us having these meetings and agreeing the way to move forward if we're not getting it done. So can we look at when you're fed names of people who might have the skills you need, that somebody can actually get back to them with it?
Absolutely, yeah. I'll again pick that up with our community engagement teams. They did have a big public drive at the Trafford Centre in the summer, and in turn, is it easier? Sorry. There was a big drive in the summer through our open days at the Trafford Centre, etc., to encourage the recruitment to first responder teams. And of course, we have far bigger teams in rural areas than we do in urban areas. But that's not to say we're not developing urban areas such as Manchester. I'll pick that up. I'll take that through to our community first responder teams.
Yeah, the idea is we're not just a scrutiny team. My strapline is always to get the best patient care in the right place at the right time within the resources we have available. Now, we only do that by partnership. Everything's about partnership this stage. So all I'm asking for is that we do look more closely at joining these things up. If there's nothing else in the matters arise, sorry.
If I can interject on what you've just brought up, Chair. A Middleton residential care home in Middleton applied for one of the, this piece of kit, and they were refused because they had applied DNR within the home. Because the patients in there have got DNRs, they didn't feel it was right to have one. Could you give some feedback on that for us in the future?
No, I'm not aware of that. I think in nursing homes they will still have AEDs, as we call them, automatic external defibrillators. And it is true there'll be a number of DNRs where an AED wouldn't be appropriate. But there'll be a lot of people in those nursing homes that don't come under a DNAR. Generally, there are a number of ways of getting an AED. Commercial entities will fund them themselves and put them, they call them public access defibrillators, and which is the ones I think we're first related to. They can be in the Arndale Centre, they can be in many locations. There are some that are placed by MWAS themselves. Now, the difficulty in understanding the Middleton one was that a liaison between MWAS and the nursing home or a commercial entity, and were they determining the best for their asset in terms of investment? There may have been a question there. Because I don't know the particular case, it's difficult to answer, but I'd be happy to take the details up. It seems a bit lacking in intuition to say, because there are a number in the home who have DNARs in place, then that kind of obviates the rest of the clients within that nursing home. And particularly if it's a commercial investment anyway, because people have determined that's the best investment of their money, and they want to support that nursing home. So, yeah, happy to have a look at that.
Thanks, Chair. Just a piece of good news. After the discussion at the last meeting, one of the community groups in my patch did want to set up a community defib. As a consequence of that discussion, I was able to check, have you reported this? Is this registered with NWAS? I'm very pleased to say, yes, it is.
And we as a committee are very grateful for that. Thank you. If there's no other matters in writing, I'm going to bring Diane with me. Diane is part of John Nelson's team, and she's going to coordinate their tower association.
Thank you very much, John. We do have some slides. I was hoping if I press the button they'd come up, but if I can just introduce the team to you, and just to say we're delighted to be here this morning, and we want to talk you through the work that we've been doing across Greater Manchester on our neuro rehabilitation services. So we have a presentation for you. I'll introduce the team, but we hope that we have plenty of time for conversation and discussion, and we can answer any questions that you have. So, as John said, I'm Diane Whittingham, and I've been leading the work on acute transformation across GM, of which neurorehabilitation is one of the services that we've been looking at. Harry Golby is our lead commissioner on this piece of work, and he'll be presenting alongside me today. We have two of our consultant colleagues with us today, Christina Walton and Marcus Fires, and they're here to share with you the consultants and the clinical perspective around these services. And have three other members of our team that are also here. Jack Sharp, you're going to give them a wave, Jack. Jack is our lead provider, and he will be the guy that will be making this a reality when we get into the implementation phase. And two of my colleagues, Christina Walton and Jackie Robinson, who have been working to help to gather all of the information and the evidence and supporting the process around developing this model of care. So hopefully between us we'll be able to pick up on any issues that you might have. So That's the team. So what we're going to do today is give you an outline of the design process that we've been through, but also to share with you more details around the levels of stakeholder engagement that have informed and driven the proposed model of care for neuro-rehabilitation services. This has been a very engaged, a very involved process. This work has been going on for several years now in terms of the redesign. We're absolutely delighted that we're getting close to being able to make this a reality now, that we have a very clear model of care that we'd like to move forward with. I just wanted to share with you about where this fits in the grand scheme of things. I mean, as you all know, Greater Manchester signed a devolution deal back in 2015, and so that we now manage our £6 billion health and social care budget within GM, and we remain unique in the country in doing that. You know, GM is a one-off model in this respect. The Greater Manchester Health and Social Care Partnership was formed back in 2016 and developed a very clear strategic plan that was called Taking Charge, and I think Warren sat over there, was one of the key architects of that plan, I think. And it very clearly set out what the ambition was for GM. And on the back of that, these kind of five themes were established. The first theme was around a focus on population health and improving population health. The second theme was around transforming community-based care and support. The third work stream was around standardising acute hospital care, which is the work stream that I've been leading. There's a fourth work stream around back office and clinical support services. And then there were a number of enabling schemes, such as technology and others, that were in the fifth scheme. So the work that we're doing here, it's not new, transforming acute services. To be frank, acute services have been transforming over the years now, and some of you will have been involved in previous discussions in this committee, I'm sure, where you've considered acute change. And the work that we've been doing within Theme 3 is built on the decisions and the choices that have previously been made. So it isn't new, it's building on that. And it's because of the activities that are going on across these four themes that acute services need to change. You know, more people in the past, you know, get admitted to hospitals when they can be more appropriately cared for out in the community. And they should be cared for out in the community. And many of the changes in the model of care that we're going to share with you today are about supporting those changes and responding to those changes, and in instances driving those changes as well. We don't want people to be in hospitals who don't need to be there. They can be more properly cared for elsewhere. And I just wanted to offer up front, I'm sure for a number of you, you'll be thinking about, well, what is the community element of this? You know, what services are out in the community? Well, the community standards around neuro-rehabilitation were signed up to 2 years ago within GM, and the localities have spent the last 2 years implementing community services. And what we are intending to do is provide, John Rouse has committed to do an audit of all of those services so that we will make sure before any changes are made in the acute sector that all the relevant community services are in place. And you will no doubt wish to share some of that information here as well so that you can be assured of that. But I just want you to let you know that we're not working in a bubble here. We're working very closely with our colleagues across the system, and the acute change is a response to what people want, where people want their care, and that has an impact on what we do within our hospitals, and that's what we're discussing with you today. Oops. And the changes, as I say, are very much about where people want their care, but also we suffer within hospitals. We have increased demand each year. You know, we have an ageing population with multiple needs and demand increases, and we have shortages in clinical staff. Clinical staff over the years have been trained very differently. They're quite different you know, in terms of how they deliver services to how they were delivered years ago, and that challenges some of our more traditional models of care. We talked about the healthcare needs of our changing population. But one of the most important issues here is that in GM, where you live does affect the standard of care that you receive in certain services. You know, you can't walk into a hospital at this moment in time and expect the same care in one part of GM as you get in another, and that's not right. And the work that we're doing here is about responding to that and eliminating variation and making sure that no matter where you are in GM, you get the same offer and you get care in the right place at the right time. And we also have significant variation in our estate. I'm sure many of you will experience that on a permanent basis. You know, we need to play to our best. We need to utilise our best buildings, and where we've got challenges, we need to do something about that. And, you know, there is an issue of money. The work we're doing is not financially driven, but clearly money is an important element of it, and it's limited, and we have to ensure that the money that we have is used wisely and is used appropriately, and we get the best value from it. So, as I've said, the programme builds on our previous hospital transformation work, and we want to ensure that people are not admitted to hospital when they can be appropriately cared for in the community, and we want to make sure that our hospital staff are freed up to do what they do best, and that's deliver the specialist care to those who are most ill. We want to create a system that's irrespective of where you live, you can access the service and be confident that you're receiving acute and specialist care in the right settings. And just sharing here that under Theme 3, neurorehabilitation is one of a range of services. The others are listed there. And we will, in the coming months, be coming to you to discuss our proposals for some of these other services as well. So they're in the process of being developed. And why did we pick this group of services? Well, earlier on, about 2 years ago, groups of clinicians, commissioners, trust leaders got together and they identified a group of services that were challenged across GM for various reasons. Either variation was great, we couldn't recruit people, or there were other challenges. And those issues could not be resolved by individual organisations or indeed individual localities. They required a much bigger solution. So it was agreed that all of those services will be looked at across the whole of Greater Manchester, so that Greater Manchester could get the best model of care for all of its patients. So that was the genesis of that group of services and why we've been looking at those. And I'm not going to bore you with this, don't worry, but you know, we have a whole governance structure that's around the work that we've been doing that involves internal and external clinical scrutiny. It involves considerable engagement of people within the system, but users, carers, and the public in the work that we've been doing. And we have tried our very best to ensure that we work very closely with all of the other themes, the transformation themes across GM, so that we are working in tandem with our colleagues and that we are all transforming services together to get the best results for our patients. So with that, I'm going to hand over to Harry Golby. Thank you.
Okay, thank you. Can I take that? So I'm Harry Golby. I'm the Assistant Director of Commissioning at Salford Clinical Commissioning Group, and as Diane said, so Salford CCG is the lead clinical commissioning group around this programme, neurorehabilitation. There are an awful lot of slides in this presentation, and to make sure there's time for proper discussion, I'm going to speed through some of them. There's no information in this presentation that isn't in your paperwork, so I'm not, you know, and ask questions if you feel that I've jumped over something.
We'll take the questions in segments rather than interrupting the flow. We'll take it at the end of your presentation.
Okay.
Thank you.
Okay. We thought as a starting point, so we're talking about neurorehabilitation, and from a Greater Manchester point of view, when we talk about inpatient care, there are a few hundred people a year who require inpatient neurorehabilitation. So it's quite, it's not a very common condition. And so we thought as a starting point, the best thing would be to do just to make sure people understand what neurorehabilitation is, So we've got some definitions. These are standard definitions that are used around neuro rehab. What I'm going to ask is for Dr. Walton and Dr. Morkos just to give you a couple of patient examples from their point of view as to sort of typical patients that they would see. So Christina, maybe. Yeah.
So I'm Christina Walton. I'm a consultant in neurorehabilitation, and I've worked in Greater Manchester as a consultant for 30 years now. And I'm currently based at Salford Royal Hospital, where we have what's called a hyperacute service. So I'll give you an example of the types of patients that come through our service. Salford Royal is a neurosciences centre, and it's also a major trauma centre, and therefore takes all the severe acquired brain injury patients, so from road traffic collisions, from assaults, from sudden onset brain hemorrhage. And for the patients who come through our neurorehabilitation service are those with the most complex needs. They're the patients who aren't going to make a spontaneous recovery without the multidisciplinary input. Our role at Salford Royal is to ensure that the patient is medically stable, so that patient can then transfer to a post-acute neurorehabilitation service where they don't require, the patient doesn't need the acute medical inputs, and that is a transition to going home. On our site, we have 20 hyperacute neurorehabilitation beds and 10 what we term as acute, and all our patients are there because their care cannot be delivered anywhere else in Greater Manchester. So we're able to provide very early rehabilitation with a team of consultants, a team of junior doctors, and all the allied health professionals, so that the rehabilitation is provided very early to make the most of natural recovery. And while the patients are often quite medically unstable and they're close to their parents' specialty, so if there's a complication, that is dealt with promptly. Okay.
Hi, my name is Marcos. I'm consultant rehabilitation medicine. I've been consultant for only 16 years, not like 30 years. I'm the clinical lead for the Greater Manchester Neurorehabilitation ODN. Just an example of, for the patient come to the post-acute, as just following Christina, the patient that comes to the post-acute is medically stable patient. However, still the patient will need intensive rehab, more frequent, and the patient wouldn't be still safe to go like in the community. The environment in the post-acute units are more homely rather than like acute, so like more rehabilitation orientated. Very, and the role of these units is to do this kind of transition to community, i.e. community, eventually community reintegration, to match the patient ability to the community.
Thank you. So if we describe the current services we have in Greater Manchester, so as Christina and Morkos have described, a lot of the patients come through as a result of an injury, so they'll come through Salford Royal, the Greater Manchester Neuroscience Centre. There are some patients from outside Greater Manchester who will come into this service as well. So in Salford Royal, that's where we have the acute facility where Christina is one of the consultants. The normal pathway at the moment is for those patients to move into post-acute beds, and we have 3 facilities across Greater Manchester at the moment, in Trafford, in Stockport, and in Rochdale, where those post-acute beds are. And so patients will generally flow from Salford Royal into a post-acute. We do have at the moment, there's some provision in the independent sector. So there are some patients with specific needs. In the papers, it talks about tracheostomy care. It talks about prolonged disorder of consciousness and slow stream rehab. Now, those are patients at the moment that our NHS services, our NHS inpatient beds can't deal with those patients. So what happens around those individuals, and last time we did an audit, there were about 40 or 50 people in that category. They go into independent sector placements, sometimes in Greater Manchester, often outside Greater Manchester, And then the final important part of our services is the community neuro rehab team. So within every locality, there's a community, or we want a community neuro rehab team dealing with the patients from that locality, giving support in the locality, and also allowing that discharge from the post-acute beds. We talk quite a lot about flow, about patient flow, and it's important to remember for this patient group, being in the right place is important. Obviously, you get the right type of care in the right place. So for example, while Salford Royal is the specialist centre, there are a group of patients where Salford Royal is not the best place for them to be because they need care in a different type of environment, a different type of care. So they need to be moved into either the post-acute beds or into the community. And the other important thing for patient outcomes, getting the right type of rehabilitation quickly. The quicker you can get it, the better your outcomes. So where we get delays, where we don't have a system that's flowing and patients are delayed in the wrong part of the system, then we can see that their outcomes are worse because of that issue around flow. Okay. I've pressed the wrong button there. Okay, so this slide describes the transformation process we've been through, and this is where I'm going to start skipping through some of these slides rather than talking great detail about exactly the detail of the process. The issue we have at the moment is that we have issues around access in different parts of Greater Manchester. We have that flow issue, that flow is doesn't work across Greater Manchester. I've talked about some specific patient groups, for example, tracheostomy care, where there's not adequate NHS provision at the moment, and we need to send those patients into the private sector. We have variation, and we have some issues around staffing. The other point I've not made, I think, in the current arrangement, we have Salford Royal as the Greater Manchester Neuroscience Centre. We have those 3 inpatient facilities for post-acute across Greater Manchester, and they're all under different management structure. They're all, one's at Pennine Acute, one's Manchester Foundation. So that some of that disjoint, that variation is part of the structural setup we have around neurorehabilitation. Okay. So the first thing we did was to create a series of standards, clinical standards, and you'll see in the presentation later on we talk quite a lot about the engagement we've done with patients and their carers. So a series of patient standards as well to go alongside those clinical standards. We've looked at codependencies. So this is about what other services need to be associated with a neurorehabilitation service. One of the reasons why neuro rehab has come before some of the other theme 3 specialties is actually there isn't quite the same level of codependency as there is perhaps for a orthopedic service or a different type of service. The key independency here is with Salford Royal being the major trauma centre and the Greater Manchester Neuroscience Centre. So that's obviously a key part. We've compared ourselves to the standards, to the national standards, in how the units, the building and the environmental standards, and we've done this gap analysis. And we've come up with this new model of care for neurorehabilitation. So the key principles around this new model of care is to get the service to be able to deliver to these patient and clinical standards. We've already approved a complex discharge team, so that's to support the flow and the movement of patients through the system for some of these, some of the most complex patients who most difficult to move through the system. In this model of care, what we are proposing is to develop a single provider model. Okay, so like I said, at the moment we have the Neuroscience Centre and the 3 other units all under different providers, different arrangements. So the proposal is for those units to be under a single provider, a single NHS provider. As a result of that, because of the way NHS commissioning works, the host commissioner will become the single commissioner. So we'll go through a decision-making process around that, but if we make the assumption that Salford Royal, as the neuroscience centre, becomes the single provider, then Salford CCG, we're the host commissioner. Most CCGs, most areas ask us if they want us to bring something up with Salford Royal, so then we'll have a single commissioner. So we'll have that clarity around the provision and the commissioning arrangements, and that will help us ensure that there's clear standards across the whole system. Diane's talked about the neurorehabilitation, the community neuro rehab services in every locality. So we are seeing, actually, what we've seen, talked about over a couple of years. Diane talked about developing some service specifications, some standards for those neuro rehabilitation, the community services. And what we've seen is clear progress over that time where Greater Manchester, the services in each of those localities are coming up to those standards of neuro rehab services. And the final part of this model of care is, again, by having a single system, single provider, single commissioning arrangements, that allows us to put together a clinical governance system to get those standards of care, to get them across the whole system. Okay. This is a very detailed slide here, and it talks about, so this is about the inpatient care, the inpatient beds. I think the key point in this slide is we are not proposing to make significant reductions in terms of the total number of NHS beds. The bed numbers actually goes up slightly in the model rather than reducing. We know that with that developing of the community services, we can improve the flow. That will allow us, the other key part of this is to allow us to get to a point where those patients who at the moment are in the independent sector, often outside Greater Manchester, we can bring some of those patients back into NHS care, and that's a key part in this. But there's the detail of the beds in here. And this is an example of the difference in terms of the new system that we're proposing, this new model of care, and under the current model. So what we've chosen here is Joe, 43-year-old, in a car accident, goes through the system, through the major trauma centre, through Salford Royal, into an acute rehab unit, but has a tracheostomy. So he'd be one of those patients that at the moment where that tracheostomy care couldn't be provided in the NHS. So at the moment goes through that fairly lengthy process on the left-hand side around placing Joe in a independent sector placement. In the new model of care, that Joe, we won't have to go through that same process. There will be NHS provision. That NHS provision will be in Greater Manchester and will be easier for Joe and for his family to access. Okay. So I think I've probably covered in here the benefits of this new model of care. There's a few slides here around the process. So this is a process we've gone through in terms of the professionals. Well, some of us have been working on this for longer than this length of time. It goes back to last year. I think the key thing to point out is in this process, so we've gone through the governance process around developing this model of care. In terms of the professionals and how we've gone through that process, there has been no real challenge around that. Nobody has been saying this is not the right thing to do. There's obviously been questions about how we're going to do that and the detail here, but fundamentally, in terms of this model of care, in terms of across the professional groups, whether that's the clinical groups or the other professionals who work, there's a consensus that this is the right model of care, and we should be moving in this direction. And the point at the bottom, that external clinical advisory panel, assurance panel, it's worth pointing that out. So that's external to Greater Manchester, outside our system. They confirmed that, and we were very pleased to note that in terms of their response, they stated that this was the most extensive assessment of neurorehabilitation that they'd seen. But they gave us that external assurance around that this is the right model of care. Now, I know for yourselves, in terms of engagement with patients and with the carers, that's going to be a very important part of your considerations. So there are a couple of slides here exactly around the engagement activity that we've undertaken. And I think we're lucky from in our system that we have what's called the Neurological Alliance. So that's a third sector organisation. So within neurological conditions, there's all sorts of wide range of conditions that you'll have heard about, Parkinson's and multiple sclerosis and all sorts of different conditions. And we have the Neurological Alliance, which is an umbrella organisation for all the third sector organisations that are underneath there. And they've been very active in helping us develop this model of care. And partly through them, partly through our services, we've been able to engage with a lot of patients and carers. So various workshops, various meetings here, and in terms of the patient engagement activity, I think there's a log of activity, isn't there, in the paperwork. But we've had these opportunities for people to get involved directly, or for the third sector who represent some of the patient groups also to be involved. And talks about 60 patients being involved, 18 different opportunities, and I remind you again, from an inpatient point of view, in terms of the numbers of patients, we're talking about a few hundred patients across Greater Manchester. So actually 60 patients and their families being involved is quite a high proportion in terms of that. And through that group, we have developed those patient standards. We've been running that model of care by them and getting their support. There's an analysis in the paperwork around travel and access. It's important to understand that we are not proposing, at the moment we have the Greater Manchester Neuroscience Centre, we have the 3 post-acute. We're not proposing changes around that. They will remain. And actually, in terms of travel, we think the big difference will be those patients who are currently placed in the independent sector outside Greater Manchester. They will actually be within Greater Manchester. We think overall the travel requirement will be reduced because of that coming into Greater Manchester. The other thing it's worth pointing out is, for a patient, in terms of travel, in terms of inpatient care, there's only really one journey for the patient to get into the inpatient bed. It's actually for their families. It's important for their families to be part of, or their carers to be part of their neurorehabilitation process. So actually it's their carers and their families who do more of the travel. For the patients, it's, you go in and you're admitted, and then you move on when you're discharged. But we have undertaken that analysis, as we're obliged to do, around travel. There's some more detail there. And in terms of this slide, there's a few more. Here's the next step. So subject to what happens today and decisions around the patient engagement side and whether there's been sufficient patient engagement, the plan would be for the model to go back to the Joint Commissioning Board to review what happens today, to undertake that options, and to make the final decision on that model of care. And then we'll go through the rest of the process and begin to start implementing Okay. Back to Diane. Okay.
Sorry.
Thank you.
That's great. Would you like me to summarise now, John? Or
Yes.
Yes. If I just only 2 more slides, if you just bear with me. I just thought it would be useful just to bring it all together, just in terms of a summary and what we're hoping to achieve through the conversation today. So, as you've heard, it's the number of patients that are impacted by these changes are small. This isn't a massive service change. It isn't a service that's utilised by thousands of people. It is a small number, very important number of patients, but nevertheless a small number of patients. And the model of care doesn't result in large-scale change, but what it does offer is a more equitable, improved patient experience and better outcomes for patients, which is the important issue. The detailed configuration around this will be determined through the business case that will be developed later, and obviously that will provide further detail on what we've shared today. But the combined approach of a single provider, a single commissioner, and a single set of GM, clinical and patient standards, which is the critical issue here, will ensure that inpatient neurorehabilitation patients all receive the same high-quality, equitable care. And that isn't happening now. So the quicker we can move towards this, the quicker our patients will benefit. And there will obviously be workforce benefits. Workforce is a very scarce resource in hospitals, you know, for all sorts of different reasons that I won't go through today. But utilising our workforce effectively and the expertise that we have is absolutely critical for us. And this is all part of this drive to change our neurorehabilitation service. We'll get a better deal from these guys if they're doing what they're best at in the right place across GM. And so what are we looking for today? Well, we hope that the standards, the scale of change, we hope you'll agree, is not substantial in view of the low numbers of patients, and we hope that you will share our confidence in that. And also feel that the model of care has been designed and developed in consultation with patients, their families and clinicians. There has been extensive engagement around this, and I'm sure you'll want to assure yourself of that. The model of care, we feel, is best to meet the needs of patients and significantly improve their outcomes. And I would just draw you to the comments of the external clinical panel, which is actually the Northern Senate for the northeast of England. So it's a body of esteemed clinicians. They felt it was one of the most comprehensive pieces of work, and that GM should be applauded around this, which is not a bad place to start, really. We hope you'll agree that the level of public and patient engagement has been proportionate, and that there is no need to go out for a wider public consultation. And what we are doing some actual testing around some of the travel analysis. Some of our colleagues from Healthwatch are helping us with that, and we'd be more than happy to share those results with you as a follow-up from today. But they're helping us just to sense check some of the work that's been done. So just moving forward into any questions. Thank you.
What you've heard is the first of a lot of change. This change is there to improve patient care. The NHS are admitting we haven't got the staff to do things as well as we could do, so we need to change it, and by bringing them together, we hope to improve it. I will say that although this is about the neuro rehab, I did speak with Dan before the meeting and with Stephen, and say that I don't want this to be an agreement to cover all the other clinical things, and that has been agreed that we will deal with those on a facing. And I'm afraid, members, that means there's going to be a few extra meetings thrown in for you. But, you know, this is for your residents, so I think we can find the time. I've already got 3 people who want to speak, but there's something else, Dan. In your papers, in Appendix 5, it's the ECAP paper. On page 14, there are conclusions. And it says, and I quote, "The scope of the new model is narrowly based on brain injury patients rather than the progressive or congenital neurological conditions. further work may need to be undertaken to ensure these key patient groups are not neglected, especially if community services are not addressed. Now, again, at the beginning, Diane assured us that community services are going to be improved. So if you start to worry when you get to page 14, we have in actual fact got the answer already to cover that. Colin, you were first on the list.
Well, this has to probably be the most detailed report we've ever seen on any element of the health service that we've ever been asked to look at any stage. It does raise some important considerations, and it is obviously a group of patients for which we would obviously want to do our absolute best on every occasion. But it also sets a benchmark. That if we're aiming to achieve this for this group of patients, are we able to achieve it for every other group of patients, whatever their circumstances may be? The answer at the moment is probably not, because of the issues that you've mentioned in terms of staff shortages, etc., standards in care, the issues with the estate and buildings and so forth. But I don't think there's anything in here that we'd probably disagree with that we'd not want to support. But I think we are keen to look at the elements around it, possibly. You've mentioned patient travel several times. That's one of our favourite subjects, transport and so forth. But it also sort of repeats the model that keeps coming up regularly, that we're looking at buildings, then look at the services, then look at the transport. Every element of change that we've ever looked at has those three elements into it in one way or another. And of course, as you've also said, finance is a serious issue. Both capital and revenue are serious issues. However, the 6 billion is packaged, those issues emerge. So the question is that one of the issues will be, of course, that given the resources that will be required to address the needs of this group of patients, you mentioned also that there are other groups of patients that may require a similar level of intensive care, etc. Are those resources going to be available for those groups? Also, I know you said you didn't want to widen this discussion, Chair, but we have to try and look at it in a slightly wider context also. And we filter down the system. Of course, we're all interested in our own localities, and of course, at one point in the discussion, in the presentation, you did refer to the need to localise community rehabilitation teams, etc., need to be established. So the whole system needs to link up. The hubs that we've talked about, I presume those teams will be part of those hubs that we are discussing or have discussed on previous occasions. It's not always clear to us. You've mentioned Salford as being a key player, the key player probably in this process. But you mentioned three others that are, if you like, where patients can possibly be transferred to as and when they reach an appropriate stage in that care programme. But it's important that we also understand how all the various trusts might come together, because clearly we are talking about reorganisation. You've not really touched upon that, but clearly that's an implication. Change that you refer to must mean reorganisation of all the various trusts that continue to make up the health provision across Greater Manchester. So I think as I say, there are a lot of issues, and I'm trying to tease a few of them out as we go along, and I know you want me to shut up now, Chair, so I will do.
I didn't say that, Colin.
I know you didn't, but the face told me. Yeah, I got that message.
Right, what I will say, Colin, is that you can come back for another one. I'll just share a little thing with you. I had the privilege of chairing what was the largest consultation in the history of the NHS, and at the time was on maternity and prem services. We were actually taken to public inquiry I remember the Secretary of State eventually bringing the report back some years later. That Secretary of State at the time sits on the other side of that wall. The members, like what Colin said, all worried about travel. Travel, it seemed to be the thing that more people asked about. So we got cheeky. We asked the mums. We asked the patients. And how far will you travel to get the treatment for your child? That is the bottom line. It's not what we think. It's what will our residents want. And Mum said, and I reminded Diana of this conversation because it's 15 years ago now, but it's something that we tend to always pick up, travel times. We've heard about various people at the time. NWAS were a very great help to us because they too have got to do it. So I'd ask you to bear that in mind. Are you going to answer, Colin? Thank you.
So you brought up a lot of points, some of which I'll be able to answer. First of all, thank you for what you said about the document and the level of detail. You should see some of the detailed documents that are behind it. But in terms of, just for clarity's sake, in terms of this model of care is about the inpatient provision. Okay, so in terms of the level of change that we're talking about having a single provider for that, the acute unit in Salford Royal and those three post-acute units. Okay, they will still be provided in the same places, but they'll be managed and they'll be under one system in terms of one provider. So in terms of that level of change, that's what this model of care pointed out. You're absolutely right, though, about how those units, how those three units work with the community and those community teams which are in every locality and are managed within every locality. That's a key point. I think having gone through this process of agreeing some standards, of ensuring that there's a single provider around those post-acute units, then we know that those units will be working to a standard, and that will help allow them to work in the same way with all those different community teams. I think on the other point you made was around travel, which obviously is an important point. In terms of the engagement we've done, so people accept when a loved one has been in a serious road traffic accident, you're going to need to move and to go to a different part. You can't expect those specialist services to be in every locality, and that's what that's what happens at the moment. And we're not proposing any significant change around that, other than those independent sector peoples outside Greater Manchester. It's when we've got that neuro rehabilitation to improve people's outcomes, to improve people to the point at which perhaps they might be thinking about moving back into their home, into their locality, in with their family, and that's where the community provision, and that will continue to be distributed across the localities. But in terms of this model of care, this is about the inpatient provision and that specialist side. Okay. Thank you.
I just wanted to address the query you had about the investment in resources. There's a wealth of research evidence that by investing in rehabilitation at this early and hyperacute and post-acute stage, and also in patients who have progressive conditions so that they're managed in the community, you're actually reducing the lifetime care costs by significant, hundreds of thousands a year.
Thank you, Chair. In the mid-1980s, I worked in the Regional Health Authority by Piccadilly Station that covered Greater Manchester and Lancashire. I was involved in a project to do with the rationalisation of neuroscience services that eventually led to the specialist centre being based at Salford Royal. At that time, our sole purpose was getting a package that we could sell to the senior consultants in neurology, neurosurgery, neuroradiology. I have no recollection of actually a consultant in neurorehabilitation. There may have been one around. Ooh, Right. Whether you were part of that committee, I can't remember. But, as I say, our sole purpose was getting a package that we could sell to the senior clinical staff. The thought of consulting with patients in that way never crossed our mind. So this is streets ahead of what we were doing at that stage. I think it's a very impressive process, clearly has responded to a lot of concerns. I'm very comfortable with the outcomes. Bringing it all together within a single commission service, I think, is exactly the way it ensures that you can develop standardized, standard care packages right across the client group, and to be able to bring tracheostomy and other patients back into Greater Manchester, I think is really good. So I'm very comfortable with this. Clearly, lots more, as Colin and others have raised. How the community-based service links into that, I think, is crucial, but that fits in with so much else that is going. How can we develop good quality community-based care in all sorts of other service areas? So lots more work to do, but I think this is a really good first step.
Thanks, Chair. Yeah, I welcome the new model of care that's proposed. My concern is when you mention that NHS doesn't have facility to provide for not all patients. You use the example of tracheostomy. One, want to know, is that the only area, or are there other areas? And two, the slide indicated that there was a provision going to be made within Greater Manchester, but that, my understanding is that won't be enough to meet the need. Is if my understanding is correct, is that going to be increased in the future? I mean, clearly that's the right thing to do. In an ideal world, we want all that provision to be provided by the NHS in Greater Manchester.
I think one of the points of the slide, Stephen, was that at the moment we need to increase, but it's not necessarily increase people, but increase the way the people are used. But I'll ask my colleague here.
So maybe if Christina answers about the clinical and what happens in the independent sector, and I'll talk a bit about the need and how we've modelled the need.
At the moment, for patients, particularly in the independent sector and also in our own NHS services, the length of stay is longer than it should be. And, you know, within our acute beds at Salford Royal, the length of stay can be several months longer than is clinically needed, whilst we're going through the processes of applying for funding and then finding a bed for that patient. Once patients are in the independent sector, the NHS overview is quite lax, and some patients can be waiting, again, for several months or sometimes even a year or longer to secure a discharge into a community setting. So we've done work around the numbers of beds, and we're confident at the moment that the number of beds that we're recommending will be appropriate, because the flow of patients will be much smoother. We'll be eradicating those barriers. We won't have to go to other people to explain why that patient needs to move to a different setting. The other group of patients that are in the independent sector are those who have mainly cognitive problems and need inpatient rehabilitation for their cognitive rehabilitation. And those patients are often in what are termed slow stream placements. And NHS England defines slow stream in a different way to what most people understand as slow stream. So slow stream means that the rehabilitation is over a time of longer than 6 months. And so typically can be a year, 2 years, sometimes even longer. But because those patients are out in the independent sector, and it's often the cognitive patients who are distant from Greater Manchester, there's no links with community services and with the local consultants in neurorehabilitation. So it's much harder to get those patients back into the NHS and into their localities. So that process takes a lot longer.
And in terms of the modelling Christina talked about, so we have gone through that process. It's in the detail behind here to look at what we think the future demand on the services are. We have modelled what we think if we get the system to flow like I described, and we do think there is sufficient provision to bring a substantial proportion of the people who are would currently be placed in the independent sector to make sure there's NHS provision. We're not going to sit here and guarantee there will never be another, independent sector placement in Greater Manchester. And it's also important to understand in terms of moving patients. So this is about how the new system will work for the new patients who come through that system. So we're not proposing that somebody's currently, perhaps somebody's in, in a placement in Chester, let's say, and is improving and has got, their family and they've got used to that. We won't be proposing to move them into the NHS beds because that's not the best for their outcome. But for new patients, there will be that level of NHS provision. So we do think there is sufficient to meet that demand.
Thank you. Yes, likewise, absolutely welcome the model of care and the process. I guess it's following on exactly my two points, really. One, in terms of recommendations, one around just going a bit further in terms of the consultation process that took place and being confident about the level of engagement taken place. And then the other one goes back to exactly the point you're talking about in terms of being confident that needs are going to be met in the future, in particular the time frames, and I can see there's a reluctance to pin down time frames and in terms of numbers, but I guess is there any more assurance or when will that come back to us? So in terms of the consultation, and absolutely welcome, as Councillor Holloway was saying, that yes, it's great what's put in here. There's clearly lots of opportunities for engagement. I do think we're proud in Greater Manchester in saying that we want to be leaders in co-production and co-design, and absolutely we want to be challenging ourselves to continue to do it better, and absolutely best practice. So I guess my question is, I can see that there's been lots of opportunities given, and given the numbers of people that we're talking about, are potentially proportionate. But I guess there's not very much about actually how what has been the feedback and how has that been responded to, in terms of we asked, we did. And seeing that in some way would be helpful in terms of ensuring that process was a genuine process in which people felt and saw that their views were being taken into account. So I wonder whether there's anything more in terms of detail that goes behind to demonstrate that. And then just to be conscious about the language, because I know at points we talk about co-production, co-design, and then other points we say in consultation with. So I guess it's just, I think there is a difference between the two and being clear about actually which one are we saying we realistically have been able to do here. So we're not setting up expectations and saying this is co-production, actually maybe that wasn't feasible. Let's just be straight about it. So then the other one was on the detail of meeting needs, and what I saw, which was alluded to before, was a suggestion there's been about 40 or 50 that have been placed in independent sector, and a suggestion there was about up to maybe 30 beds in the future was the intention, and completely understand that it takes time. You don't want to move current patients. I've been there, I've seen, you don't want to do that. But is there anything more you can give in terms of when we will understand what that time frame looks like, and when it could come back to give us the reassurance that this is clearly that intention is going to be realised, and when?
Okay, so in terms of the engagement work, so Marcus was involved in a lot of the engagement work, so I'm going to ask him to speak about that. I think in terms of the key part of that, we talked about clinical standards and patient standards, and perhaps we can talk about those patient standards. In terms of your point about co-production, you're right, we engaged with a lot of people. There was clinical engagement, there was kind of managerial, there was all the estates people, as well as patients and carers. So, we had to engage with all those different groups. I think if I let Marcus talk a bit about the engagement work, and then I'll come back to you on the timescales.
Thank you for the question. Basically, I'll try to summarize, and I was really worried about this question because I'm not sure if I'll be able to remember all the events and all the engagement we had. I'll try to summarize that. So basically, we had certainly patient and carer engagement. We had staff engagement, and have engagement with social services too. To just make things simple, we have ongoing engagement for kind of more or less every level. For the patient and carer, we have a representative in the network board, and we have kind of one representative from Greater Manchester Neuro Alliance, and a couple of actual representatives were being appointed by the network to attend the board meetings. we have kind of in separate patient and carer group that actually meet every 2 months, and they were involved more or less all the like the specs, the guidelines, even the publications, the audits and all that stuff, and actually in developing the new model of care. As Dan mentioned, the model of care being driven and decided along with the patient and carers as well. So to start up with, we had visits. We went to all locations and we invited everybody basically through the service and through other groups like Headway, Head Matters, and MS Society, etc. And we met with the people to just listen to them. We had actually a big event at Sarful Royal, and from this, it was very well attended as well, a whole kind of afternoon and evening, and we produced at the time that patient-driven basically standards, and we worked in these standards actually to produce the model of care. The service design actually group, we had another event which attended by clinicians, commissioners, managers, and patient representative to actually look at the options of the new model of care. And after that, went back to the patient carer group, and we scored every single option, and we rated all the options, and basically we picked the highest option scored. But in addition to that, basically we have a website, we have Twitter, we have emails going backward and forward with these groups, and we have really regular contact. And they've been actually very helpful, I have to say, have been very, very helpful. With the staff, again, is extensive involvement with the staff, because actually the whole thing was driven by the staff. We, again, went around all the services, met with the staff, again, listened to them, and when we had the options, we went back and presented. The staff certainly were involved in the production of the model. The staff were involved in scoring the model. The staff are involved in producing all the specs, all the guidelines, and they were involved in auditing the specs and the guidelines too. I'd say that I wouldn't finish in this, but the last thing, I'll go back to the social services, because again, we have Trafford actually is the social services representative in our board, so they were attending. And we did go to ADAS in few occasions for further discussion, and actually the social services were the leader in developing the complex discharge team, which is almost up and running now. We had all the funding, and we're recruiting the staff at the moment. So like we had lots of engagement for all the levels. Is that okay?
You come on.
Do you want just in terms of time frame? So I think the presentation talked about the decision being made at JCB in December, and then we'll get into the implementation point of view. There will be we'll need to go through a process of still some detail to clarify. There'll be a detailed business case, and as part of that business case, there'll be an implementation plan, which Jack, who's sitting behind me, will probably be the lead around that implementation plan. I think we would expect to be starting to implement the model early in the next financial year. That's where we'll start to make those changes. I can ask Jack about, or if you want, we can talk to Jack about how long it would take to get to the end point of that new model, but we haven't got that detailed implementation plan ready yet, because we need to get the decision first of all. Is that okay? Would you like me to comment?
Hi folks. So obviously this is a really important change, and it's important that we do it right. So in developing the business case, we'll need to set out each of the key steps, and indeed some of our options for how we approach implementation. Worth noting that GM, I think, has a good track record in implementing significant, important changes for our population that span multiple organisations. In this case, it's critical that we've got really strong clinical support. We've heard that already. It's also important to note that each of the other providers of the post-acute services fully endorse and support the model of care. So that's a really important foundation. We will do the things that we have successfully done in other areas. We will establish a programme board that will have representation from across the providers and key stakeholders. We will ensure that we continue to engage patients and service users during the process of implementation. There'll be some things we want to do quite early on, I guess, to secure some early wins, so establishing a single clinical leadership structure, because that will start to drive our standards, a common approach to professional education, training and development, using some of the infrastructure that we've already got through the operational delivery network to coordinate the work. There'll be some options about how we phase the changes in terms of implementing the model of care in each of the units, and I don't want to prejudge what that will look like, but I am personally keen, having been part of this journey for a few years now, to ensure that we mobilise this during the next financial year.
And that information we brought back to Tracy.
Indeed, happy to do so.
Thank you, Chair. First of all, I welcome this package. My daughter in August actually had neurosurgery at Salford, still under their care. And one of the most frustrating things was we were informed on 3 occasions surgery delayed because of lack of beds. I don't like to use bed blockers, but that was the problem. She since received the surgery in August. And one of the frustrating things is that because you're under Salford, you go back to Salford for a consultation and the travel. And it's so annoying because A, she can't drive because she's had neurosurgery. So that means family involvement and everything else. And with the air pollution problems we've got in Manchester, we're creating further health problems for the rest of us. So I do welcome this. One of the other frustrations things is on the consultation, why we don't use the GP and Skype and interconnect without the travel. Now, whether that can be introduced into local hospitals and what you're actually portraying here on the mapping of Greater Manchester, that really would be ideal. And the only question really I've got is there a financial gain in this package, i.e. that obviously we're not sending people and patients out of Manchester, and what is the saving then for stopping the people coming into Manchester, or is there a environment cost we charge other trust boards?
In actual fact, having gone through all the appendices, excuse me, this is going to cost us a little bit more. So it's not about saving money, it's about using that money. It comes back to that strapline of mine. It's to use those resources in a more effective manner. You're going to have more beds, but you're going to localise it. You're going to bring it back under NHS control, which improves the quality. We're scrutinising this, but I have taken the time over the last few weeks to go through this and look at the detail. Now, you brought up a couple of very good points, Ray, there. When people are sent a letter saying there's an appointment to the hospital, they tend to book time off work or make arrangements for care of other members of the family. I can give this committee, if need be, the paperwork trail from one patient who, to the spinal unit, 5 times was given appointments and then back. So I was asked to get involved, and I looked at one of them, and I phoned them up and said, why is this boo back? Well, the consultant's got an emergency in theatre. Now, I've been told I mustn't swear on camera, but I did actually swear at that point because I've been around acute healthcare for 40 years. I do not understand an emergency in theatre 11 days before the date. That isn't how things work. And I have spoken to Dan about this, but this is really where an administrative person's got to find some answer to give that person. But 5 times that patient and his family were made to change all their arrangements, so that was wrong. Now, you say about using Skype, etc. I couldn't comment on that, and I think Harry's going to in a moment. But I do know that rather than you spending time dragging into a hospital to be told by a consultant, we need to send you for a CAT scan, and then make another appointment. That again comes back to that favourite word of mine, which are round and spherical, but again, not allowed to say it. So all it needed is somebody, and it's more effective on the clinician's time, to phone that patient up and say, right, we've got your results so far, we need you to come back in for a scan and move on from there. It saves the hospital money, it saves the clinician time, and it is far more less stressful for the patient. So, you know, well said, Harry.
Thank you. I think there was an awful lot in there. You talked about spinal surgeons, you talked about neurosurgeons, and absolutely I recognise the issue. And you know, I could talk in some detail around the work we're doing locally in Salford around virtual appointments, you know, telephone appointments, using technology, those kind of things. I think from the neurorehabilitation point of view, I think in terms of the clinics that Moorcost does, it's important to understand in terms of outpatient clinics, they're not all in the central unit, they're not all in the hospital, they're not even all in the three community, acute, post-acute facilities. They are spread out across the localities. They're much more local, and they will continue to be local in terms of those outpatient provisions from a neurorehabilitation point of view. But absolutely, in terms of some of those challenges, which all parts of the NHS are under, I absolutely recognise your point.
Thanks very much, Chair. I've just got two little questions. One's just a clarification, really. You did say in the presentation, but I couldn't find what I'm asking in the paperwork, that you're expecting the demand for neurorehabilitation to increase. And I just wondered whether this was because of the ageing population, increased population, increased incidence of brain injury, or a combination of any other reasons. It would be interesting for my knowledge to know why you're expecting that increase. And my second question is a bit more specific, because on page 10 of the, I think it's Appendix 1, it's saying that there are 3 areas of Greater Manchester that don't have a specialist community facility, and Bury is one of them. And Manchester is now getting one, so that'll leave Bury as the only one without. So I was very heartened to hear you saying you're wanting to standardise the community services and get them all communicated. Now, I realise Bury is the smallest borough, and it's not that far from Rochdale, although we've heard about transport problems, and basically, although Bury can get into Manchester reasonably easily, getting to Rochdale isn't always easy. So I'm just wondering what the plan is to extend the community services to Bury. Thanks.
So I talk about the community services, first of all, and Christina's got a hand up to talk about changes in demand, which is something we've been discussing quite recently. So in terms of community services, that picture in the paperwork is changing and it is improving on a regular basis. So what's happened is that through the operational delivery network, so a set of standards around community provision, a service specification for what a community team should look like has been agreed. That's been through John Rouse and his committees as well. And what we are seeing is individual localities going through a process of confirming their investment and their support to those community teams. So that's a business case, that's a commissioner decision. And then once those decisions have been made, those services being implemented and taking a bit of time. But we are seeing that improving position. Moorcost will probably jump in. I believe that Bury has gone through that process of getting the business case. We're also seeing from John Rouse that Greater Manchester will be talking to individual localities and making sure that the individual localities are actually implementing those agreed standards at community level that we have agreed. So from our CCG point of view, this Friday we have a quarterly meeting with John Rouse's team. We're not sure whether it'll be brought up this week or at our next meeting about where we're up to, but from a Salford point of view, we've gone through that process of agreeing the business case and making the investment decision, and then looking now to see how quickly those community services can be expanded up to the new standard of care. I don't know if Marcus wants to say anything more about community services, and then Christina about demand.
It's just last week I was in a meeting with Bury CCG and they approved some funding for expanding.
So that's moved on since this came out?
Yes, actually. That's like brand new information.
Any reasons for the increased demand that you're anticipating?
Absolutely. The acute care of patients has improved considerably over the decades. There's lots of evidence now that the initiative of major trauma centres has improved outcomes and survivors from major trauma. By centralising, the very specialist needs, the patients who need very specialist care, the outcomes are better. And we've certainly noticed at Salford that since Salford Royal became a major trauma centre, the demands for patients with very complex needs has increased. Another factor is that we have improved our care of managing long-term conditions. So people with conditions like multiple sclerosis, muscular dystrophy, cerebral palsy are living longer. And so that demand is increasing. There is the age demographic, so people are living longer and people are living very active lives for very much longer than they used to. And again, that is adding to the demand.
Thanks very much.
Several times, Chair, but and it was just touched upon at the end there in terms of flexibility, adaptability, that we're creating this sort of intensive care program. And again, you've touched upon it, increased demand, number of beds, etc. 200 patients approx per annum. I think what we're interested in is how flexible or the system may be in catering with different kinds of clinical issues, etc. You've talked about access and flow issues, how adaptable the staff may be in those kind of circumstances. Given that that there is intense pressure in terms of staffing and resources across the system, how are we able to adapt in each of these situations where there might be increased pressure or less pressure, as the case may be, but more pressure in other areas, and can we move resources around easily, quickly, in order to respond to those kind of situations?
We have a long history of adapting. The model that we're working to at the moment was implemented in 2001, and the way that we've worked over the last 17 years has changed and adapted to patient need. With implementation of the proposed model of care, we're likely to retain staff. At the moment, particularly our allied health professionals, so the physios, occupational therapists, speech and language therapists, can only get to a certain level in clinical work and then often have to leave, and they often go and do private work because they can't progress in the NHS. By having an integrated service with a single provider, then we can develop those staff so that they can maintain their expertise and sort of their flexibility. We have to adapt to the healthcare needs of the population. I think I've answered everything.
Roll the drums a little bit. One of the things that makes this committee work is that we have some continuity in some areas. I think the first time Stephen and I worked together was with making it better, wasn't it, Steve? Yeah, with great respect to what Colin said about the detail in here, in those two previous ones, making it better, we had so much documentation, it was unbelievable. I say we did end up at a public inquiry, but this is the first phase of theme 3. And I'm sorry, guys, but this is going to get a lot more coming to you over the next few months and into the next municipal year. And with that in mind, I would make a plea now for you to keep the continuity It's the same with Warren. These are the people who help us run this committee properly by having the right information. So away you go, Stephen.
Yeah, it's good to make your reacquaintance, John, actually. Sort of, so just a couple of points, actually, just in this. A general point and a specific point, actually. So the general point is absolutely John's point, but this is, at one level, just road testing through on a discrete service, a very important service, but a discrete service, actually how we as a system across Greater Manchester start to address some of the significant issues that we need to address across theme 3. So at one level, this is a very, very detailed report. I've seen some of the more detailed reports that sit behind some of this stuff, and the level of detail can be overwhelming if you presented it, you know, almost cold sort of thing, when colleagues have been involved in enormous amounts of detailed and considered work beforehand. So the broader point is actually, I think it's going to be quite helpful if we could offer you some sort of more detailed stuff as Theme 3 starts to come forward, some detailed workshops that allow you to sort of probe underneath some of this stuff rather than actually try to deal with it on the face of a meeting. So I think there's an offer there from myself and from Diane and colleagues in terms of doing that. And I know from chairing the Joint Commissioning Board, which runs at the side of this, I know colleagues there would have valued that as well, and therefore we're developing that sort of response. So there's the offer in that space. The more specific point is, I think as we start to sort of consider these, if you like, business cases, what we've recognised, of course, is actually they don't exist in isolation, and there is a conversation that runs almost in parallel with this piece of work, which is about what actually the offer exists within community services, and in every piece of work that I think that John and I have been engaged with, this conversation has taken place. And so with this piece of work, there was a commitment from individual localities that actually up front they would actually start implementing some standards around community services that would map onto this work. What you see from the paperwork, that localities are in a very bold position in terms of some of this stuff. And so what I think we should be doing, because actually I think we're going to be asking this question each time we come to a theme 3 theme, we need to have some reassurance through this process and through JCB that actually localities are bringing that work forward, because they're committed to do it, but we need to make sure that actually it is actually in place, because it's complementary of the two. And I understand the point that John Rouse has got an internal NHS quality assurance report, but actually, which is great, but I think it's for this scrutiny function in JCB to make sure and get some assurance that that actually is in place. And my recommendation would be to add a recommendation to the slide that actually we bring that forward, not to impede this piece of work, but actually to provide some public reassurance that actually we've got those community services in place, and we should do that at the next meeting.
On that point, as I say, there are a couple of things, I might as well say it now rather than at the end. Stephen's right, there's a lot of information there in those 9 appendices and the actual report form. I'd ask you now, having heard what you've heard in the last hour and a half, that when you get home, to go through that again. And if there are any more questions arise, email them in to the staff, and they can disseminate it to Diane or Harry or whoever. But it's you, now you can take this on board and work out what more you want to say. I am going to ask something that's not on the agenda. Rob, again, we've worked together for many, many years. As a commissioner, what do you see the problems or the benefits of what we're doing here?
Thank you, Chair, and thanks for inviting me to comment. First thing to say is that the Joint Commissioning Board, which Stephen's made reference to, and Stephen co-chairs, has spent a lot of time over recent months looking at this piece of work, as has the wider commissioning system in Greater Manchester, as personified by Harry this morning. So I think all that's being said, all that has been said around this table this morning does represent the strong view of commissioners in Greater Manchester, and I don't think I can add very much to what more steps to take in this process, both of which need to take place in the light of today's discussion, in the light of the input of this committee. One of which is in December to sign off this approach, what you've heard presented to you this morning, and then in the light of the further detailed work that Harry described in the early part of 2019 to actually sign off what's described as the preferred provider, which is effectively firing the starting pistol to actually get on with making this happen, as Jack described a few moments ago. And it's very important, in my view, that we make that progress quickly. The JCB, the Joint Commissioning Board, is the formal decision-making body for this work. It is obviously wants to take very close account of this conversation this morning, but equally is very keen to get on with this along the timelines that Harry set out in his presentation. So through you, Chair, I'd just ask colleagues to note the timeline that the JCB is seeking to follow around this, that a report back from this meeting and any subsequent questions that come in will be taken to that Joint Commissioning Board in December, but we're very keen that we can make a decision early in the new year in the full sight of this committee and to allow us to start delivering the improvements to the citizens of Greater Manchester that we've heard about this morning.
Thanks for that, Rob. In actual fact, with all of the officers, we need updates. We don't necessarily have to have them at the meetings, but if they can be emailed into the Command Authority, they can then be sent out to the members. Now, in a similar manner, very briefly, can I ask NWAS, these changes, because this is the first of many that we're going to go through, what impact's that going to have on your service, if any?
We've not discussed in detail the conveyance of patients in and around the Greater Manchester area. Generally, we are sat within the consultations around that. If you recall the reconfiguration of Trafford, meeting the need and other health configurations, our concern would only be on increased journey times or increased journeys per se, and how that would affect our normal core provision, but I'm sure we'll pick that up in the joint consultations.
And again, you'll come back to us as and when.
Absolutely, yeah.
Thank you.
I think just to reassure the committee, we do have regular discussions with directors at the Ambulance Trust around the work of Theme 3 so that they understand the considerations that we're making at the moment, and they are very clear about when they want to get involved in the detail and when they want to work with us on that. So, you know, we have those regular discussions with them. They're part of our governance architecture, and they input at the relevant times so that they can contribute effectively. And obviously, we want to be very clear about any implications for colleagues across the service, particularly the ambulance service. It's much more relevant on some of our other work streams that we're looking at, as opposed to this one, where the numbers are much smaller.
Thank you. In conclusion to this report, I've asked for the recommendations we put back on screen. I'm not going to go through them all, but let's just look at that first one. We're asked to agree the scale of change is not substantial. There is a reason for that. If we said this is a substantial change, the whole way this must be done about consultation changes. This is a substantial change for us, but not in the legal sense of the NHS. So I'm going to ask you just very quickly, do we agree that this is not substantial change? Agreed. Thank you. We know the model of care was designed. Yes. We agree that it will improve the needs. We agree the proposed model will meet, and I think improve, as I was going to say, the needs of patients and outcome. We agree to that? Okay. We agree that the level of public engagement has been proportionate, and therefore agree there is no need for wider public consultation. I personally have a little bit of a problem with that statement. You can hold public consultations. I think when we did Making It Better, which was the second largest one, we had God knows how many public consultations, but it wasn't the people who came to the consultations. They were a relative minority out of the 2.8 million people. It was a...
Suggest about 3 words, Chair, at this stage.
Well put. So I think we do need to look at other ways of communicating with the public. All right, but subject to that, we would agree to that level of public, and basically, as long as we get the updates, we agree to that. I think, in general, having spent over an hour and a half on this, I think we've been as informed as we can be at this point in time, and I would suggest that we agree for this to move forward. Thank you very much.
So in the discussions, I've got a couple of more points. One, that the further report on community services be brought back to the next meeting, and in particular reference to this aspect of theme 3. And then that the committee be provided with continued updates on this work, whether sometimes formally in meetings, but you know, there's a constant flow of information. Yeah.
You are going to be notified, behave, you are going to be notified of these extra little dates, because we've got to get it right now at the beginning, so that when the next stages of CMP come through, you've already got that grounding down.
Can I just clarify, John, on point 4, that what we've agreed is that we're agreeing that there should be ongoing public engagement, but that there is no need for formal public consultation? No. That's what we've agreed? Yeah. Yes. Okay. We're all happy with that. Okay, thank you. Just wanted to clarify. And thank you for your time, and we'd be delighted to do some kind of further informal sessions with you on other models of care, and hopefully you'll find that helpful with our ongoing discussions. But thank you very much. Thank you.
I've been requested that we take a 5-minute break for a variety of reasons, but I'm sure you can get more tea, coffee, or whatever, okay? Right, colleagues, can we make progress, please? Next item, thank you very much. We had a review on variation in NHS Ambulance Trust, it's the title. We asked NWAS to respond to this, which is why they're here today. We were sent a report, and I'm sorry guys, but I accept that what went along with the delivery of that report was the fact you've had changes in management, etc. I think we can improve on that. So your chance to respond, please.
Thanks, Chair. Thanks for inviting us as well to talk about the provision of ambulance services. The report, as you rightly state, kind of tees up the variation in ambulance trust provision across the UK, particularly around the 10 ambulance trusts and their responses to the review. And my view is it also seeks to speed up a lot of initiatives that are already in train, i.e. care closer to home, etc. Many of the things in the report are not new or radical. It's actually comparing trust and saying the speed of change in each of these trusts has wild variance. And also some of the initiatives exist in some and certainly not in others. So it compares trusts and then seeks to use that variance and then talk about how it might be addressed across the UK. So if I can just quickly go through this presentation, I'm conscious of your time, but it kind of gives you a sense of where NWAS is. In response to your previous question, Chair, in terms of the report, are we referring to the standard narrative that was forwarded by NWAS to support this discussion? Okay. In terms of improvement, was that too little detail or didn't?
Go through your report and then the members will
Okay, no problem. Okay, just to give you an understanding of the size of the trust and the provision of service of NWAS, of course, it's a northwest provision across a regional footprint, 5 counties, Cheshire, Merseyside, Lancashire and Cumbria, and Greater Manchester being the greatest of that. Greater Manchester can kind of command at least 38 to 40% of the activity. Even though it's one county, it is by far and away the biggest in terms of centering of population and being the most urbanised element of it. We employ 6,000 staff and we accept 1.23 million emergency calls. Part of where this report makes reference to is the complexity of the environment in which the ambulance service operates, and therefore how it consults with its partners and how it affects the speed of change and integrates within the wider health service, which does present an incredible challenge for the ambulance service. And that kind of gives you a view of where a regional ambulance service cuts across so many footprints and then has so many imperatives where it has to consult, collaborate and work with its partners in health. The service we provide, urgent and emergency care, patient transport services, resilience and NHS 111. Our strategy is to improve our services to the point where we might be the best ambulance service in the UK and providing the right care at the right time in the right place and trying to do that every time. Our mantra, as you see below there, we focus on initiatives before the call, while we're answering the call, providing the right care when we do so, responding to the needs of our patients and hopefully directing them to the right place. Again, a real focal point of the Carter report about how we might do that better, not just in Greater Manchester, but across all services in the UK. One of the biggest challenges we've had in recent times was the introduction of the ambulance response programme, which was a change of the performance standards. The ambulance service in the Northwest actually undertook the pilot in August of 2017. It's fair to say we're still wrestling with balancing our fleet and resources against the new demands of ARP. In terms of the ARP objectives, it was intended to give a timely response to life-threatening patients in terms of a number of different conditions, and it was felt that the new response standards make every patient count, whereas the old standards were somewhat more aggregated and allowed, if you will, game in between it, whereby it didn't focus on every patient. So, in terms of the ARP, it determined that ambulance service would have to restructure its assets, whether they were vehicular or human, to produce against the new standards and to do things differently. Again, that's just narrative and a schematic to support what the intention was, to get the right vehicle with the right skill mix at the right time, and to prevent, if you will, less multiple responses in certain circumstances. A lot of ambulance services became complex to the point to meet certain standards we're responding multiple vehicles, and that was increasing. The aim of ARP was to reduce that and maximise resources, one of the aims. Again, how do we, how does it change and benefit patients? Again, at the front end, the call taking was expected to change radically to make sure we focused our resources immediately on the most life-threatening calls, whether they be cardiac arrest, stroke, or any of the derivatives that would be considered life-threatening, and hopefully sending the right skill mix and resource immediately. I won't go into the definition of the standards there. It's probably something that you'll all understand now. These standards have been in for some time.
Just to check, can you go back to that?
Yeah.
You really do mean the mean as the average?
Sorry.
You took go one more back. No, sorry, forward then. Next one. That's right, that one. The last time I got involved in emergency ambulance services, one of the standards was that 50% of calls should be met within 7 minutes, 95% within 14 minutes, something like that. And that made a lot of sense. The average time in it can be dramatically skewed by a very small number of very, very long response times. So I'm really puzzled that really is the performance measure now.
It gives you two measures. There's the percentile and there's the mean. So, for example, on the most life-threatening calls, we have to get to them within 7 minutes. However, on the percentile, so 9 out of 10 should be within the 14. Yeah. So, in essence, you quite rightly describe what we call tails. If we have one incident within there where we leave a patient for too long, it really does undermine your potential of it in that performance within that 24-hour period. But that, in essence, was the focal point of ARP, to make sure every patient counts. So you couldn't... The old standard, once you'd missed an emergency, it didn't count for the performance. It was missed, so that patient could wait longer and longer and wouldn't contribute. So, in essence, there was a thought that once services had lost a standard, that the patient didn't matter. Now, the tails carries on growing and affects us. Does that make sense? It's so every patient counts.
The only issue, that I don't know what happens, but certainly what could mean you'll have quite significant swings sort of month by month in the mean that you calculate in that way.
Keith, can we pick that up? I'm sorry to interrupt you, Pat, but this committee is a GM-focused committee, and I appreciate NWAS is a 5-county, as you said in your opening slide. Do you have any more focused times for GM?
Yeah.
Thank you.
I'll fast forward it, if it pleases the chair, to these are the times as we speak now. This is year-to-date figures in terms of... on the most life-threatening categories, you'll see we're in green there on the percentile, and we're very close in terms of the mean as well. We would sit well nationally on those standards. However, on the C2 mean, the next category down, we're struggling to hit the standards there, which would be 18, where it says 23, which was yesterday, and it should be 40, where it says 48. Down below, the mean in 60 minutes, we're 4 minutes out beyond that. So as you can see, there's a lot of below standard performance, and clearly the Carter report gives you a kind of insight into some of the reasons why that happens. And so I'm happy to push past that, and then I'm conscious the committee have read the narrative from MWAS about the Carter report and our standard responses, and if I flash through this, happy to answer the questions if that helps. Yeah. So again, the performance improvement plan was a joint commissioner and MWAS approach to how we would meet the requirements of ARP. There was a radical approach from the commissioners that involved investment of £3.5 million, but a realignment of our existing resources. So for those of you who saw an incredible amount of rapid response vehicles, we enormously reduced the number of those. So for example, in Manchester, the original number would have been in the region of about 60. We reduced them to round about 38. And in essence, the new standards required less of them to hit the small number of C1 emergencies. Rapid response vehicles would not have hit a C2 target. It required a conveying vehicle, which was a double-man paramedic ambulance. So we had to radically realign the fleet in the last few months to the point where that realignment is complete. And we're still recruiting now to populate all the new vehicles. So we've created 20 additional double-manned ambulances within the daytime period in Greater Manchester, and reduced the RVs and using the clinicians from them onto the vehicles. So
again, sorry about that. You say 20 numbers are great, but out of how many?
The peak fleet at one stage would have been 99, and now it's around in the region of 190. Yeah, about a 20% increase, yeah. But the embedding of that is still in train now because of the recruitment catching up. We've got about 90 vacancies currently. Within the workforce plan, that should balance by February. So, again, a lot of detail on this, but the call pickup, there was a hell of a lot of investment through the performance improvement plan, working with commissioners. Our call pickup was not where we would need it to be. A lot of trusts in the UK, when they introduced ARP, because they weren't answering the calls quick enough, they were getting secondary calls and tertiary calls, which slowed down the call pickup. It created an incredible problem. We've now improved the processes, and we also have auto allocation now for C1 calls, which shortens. It's an automated system and shortens the call length. The skill mix and the fleet, which is what I've just described, we're in train now with adjusting that and creating more double-manned ambulances to respond to the broader range of performance and imperatives within ARP. I'll talk more in relation to the questions about whole system changes required so we can succeed. It's about the whole health system to create the environment in which the ambulance service needs to move, and as a result of the Carter report, I suspect it dictates need to expedite that journey somewhat better than we have done in the past. This is a key area where we are currently in discussion with our partners in the acutes, with Greater Manchester Health and Social Care and the commissioners. Where the hospital turnaround times increase, we perform worse, and that's a natural thing. If we can't get the ambulances back into the community, we can't get the next response. Sometimes on any given day we can be stacking 100 ambulances 100 calls with ambulances, maybe a quarter of the fleet not being released at hospitals. Where you see the red targets down the left-hand side, they should actually be 15 minutes. 15 minutes on the right-hand side for the ambulance services in green, but we would hope to push more and more towards 10 minutes for the ambulance service. But we really need to do some work about the impact of the acutes, and we're working with GM Health and Social Care on a Greater Manchester handover policy, which is quite forceful in what it implies to the acutes they should be doing. This just shows you a 26-week average of the turnaround times, both ambulance and hospital. As you see, it's 19 minutes heading for 20 minutes with the acutes and 12 minutes with the ambulance staff. In terms of taking our performance standards seriously, we're committed to delivering the excellent patient care, working with our commissioners and partners in Manchester to try and create the right environment where we can make more and more referrals within the community, as opposed to heading towards A&Es that have their own performance issues and therefore a longer and longer turnaround period. I'll stop there and invite questions.
Colin, you already noted you want to speak. Can I take a note? Who else wants to ask questions on this? Go on then, Colin, you do it.
I think the points be well. One of the most significant points has been made here. We've been talking in the last meeting, in the last report rather, about access and flow issues. We're still talking about access and flow issues in a sense, in terms of particularly in relation to A&E. And you, as you say, stacking up ambulances will obviously undermine your ability to continue to meet your targets. I think that's going to be one of the, but that's an improvement you're talking about across the whole system, as it were, and probably every A&E in the country is addressing or attempting to address this challenge in various ways. How we reorganise and how we localise the services across Greater Manchester, as it were, across the 10 boroughs, will obviously impact on your ability to improve your targets, as it were, depending on how efficient and effective the local reorganisations prove to be.
I think that's a fair reflection of it. We have a complex tapestry, each component of which improves our potential to hit our performance. So, for example, greater access to community services. So what we would say, very accessible, no frills entry criteria into an AVS system. AVS is where we can refer to doctors in the community, and they'll take our call and they will say, actually, we'll take that referral off you. Don't transfer that to hospital. Very much no frills. Ambulance staff who are with a poorly patient can quickly refer on. Urgent care centres, which it is planned within the Carter Review to reintroduce and make accessible to ambulance staff so they can make the referrals. So yes, we're totally dependent on the landscape in which we have to work. But that said, there is an incredible amount of dialogue between health partners, GM Health and Social Care, and GM Health and Social Care have created a document that all acutes have signed up to, which is almost a zero tolerance of ambulance turnaround times. Now, that's fine in saying that, but sometimes their capacity issues far exceed or their ability to meet those capacity issues far exceed what you would expect as the norm, which we call peaks and troughs of demand. So we are working with them, and there are many initiatives such as the engagement of clinical coordinators in the A&Es, an able person who will meet at the front door, who will look at flow, who will look at ambulance traffic and other patients, and try and take the patient from us at a lot earlier point. Also drawing down nurses from the wards, some people have referred to as part of the Dunstable model. There is a greater appetite now amongst acutes than there ever has been to accommodate us and work with us, whereas in years gone by we've seen a trajectory upwards. We've actually seen a balance now, still not where it needs to be, but we feel the dialogue in Greater Manchester now probably is at its best to resolve this problem.
Just a couple of connecting points, if I may, Chair, because I think although we're recognising NWAS is a 5-county service, I think through the course of today's conversation and what we've touched on in the past through this committee, there's a very distinct Greater Manchester agenda where we need to make some of those connections. So thinking of the kind of the change proposals around some of the acute services and what that means for emergency and non-emergency patient transport supported by NWAS, they're a necessary part of our kind of planning and strategic reform agenda. Where we've got some of those issues like delays in handover times, where delays and stoppages and blockages in one part of Greater Manchester actually materially affects the ability of the ambulance service to make emergency response in another part of Greater Manchester. We've got a common interest. So I think that's why we got to that point of actually we need a handover and turnaround protocol that operates at Greater Manchester level. The other key bit is linking to our conversation last time around the local care organisations, because the key to avoiding the need for the ambulance to take a patient to hospital is the ability to tap reliably into community-based care. So the development of the local care organisations in every part of Greater Manchester is the kind of the promised land, really, in Greater Manchester being able to radically reduce the level of conveyance of patients to hospital. And the challenge, I suppose, for the local care organisations then is the extent to which they provide absolute clarity, reliability and certainty for the ambulance crew that says, actually, if I'm in Tameside and I think I don't think this patient needs to go to hospital, I need to know there's a really straightforward route that is referral into the community and that can be received.
Warren, a lot of what you said was basically on the script here. I don't mean your script, my script. A year ago, this committee was getting a little bit frustrated with times. The papers, the MEN especially, were picking up on specific cases, which I know were the exception, but Derek came in and spoke to the committee at length, along with Jed. At that time, I put forward what is maybe an oversimplified idea, which Warren's touching on a little bit there. If you go in as a walk-in patient, you're triaged almost immediately. You might have to wait 2-3 hours afterwards, but they know what you're doing. And I put forward an idea that when an ambulance arrived at A&E, somebody there should take responsibility. That is not your role to be that function at the hospital, but the hospital should take that patient off you. And in my simplified model, put forward an area where you go directly to deliver and triage. Now, the feedback from one large hospital in the locality was, what if there's an emergency? Well, there's no more difference if there's an emergency on the ambulance than if it's in the hospital next to A&E, is there? You know, you're not there to deal with the emergency. You are there to deliver your patients in the best state they can. So to say now that nurses are coming down, etc., it really relies, and Stephen, this comes back to a certain extent to the partnership, we must have the hospitals taking some responsibility to accept these patients more quickly off the service. Because if they can do the handover, 30 to 40 minutes, quite honestly, it's not good enough. Because that means every ambulance, 1% of the ambulances at peak time are off the run because they're waiting for somebody in the hospital to take responsibility. And I'm sorry, you know, this is on record, but I'm stating that as record. So what you said, Pat, and what Warren's just said, means that somebody is meeting some of that concern, but I don't think it's happening fast enough. And therefore, on record, we need to see some change from the trust rather than from the ambulance service. The ambulance service are just part of the process, but we need the trust, the A&Es. But block capital, size 36 font, by triaging the phone response, is it an ambulance? Is it a hospital need? You're doing that already. You think you don't need to go to hospital. Refer it back to primary care. At the next meeting, I think it is, Tracy Vay is coming along to talk about the primary care attitude to this. Where they've done certain samples by changing the GP hours, they've reduced by up to 20% some of the A&E attendances, which takes the pressure off you guys. So it's all about various parts of the NHS in GM working better together. Are there any further questions for these guys? I hope you note this. I think Susan's going to be talking to your new chief exec, interim chief exec. It would be nice if they could come along in January and introduce themselves. Jed comes frequently enough, but Derek used to. If we can agree for that.
I would pick that invitation up, Chair. If you let us have some diary dates, we'll arrange that. I know you've got a visit to Parkway as a committee as well.
Thank you for reminding me. Sorry to interrupt you.
13th of March, to show you how we work within the system and the GM Hub, the GM Health and Social Care Hub.
Derek, your previous chief said he invited us, he made the offer to us on 2 occasions that we could move our meeting to Parkway. Now, I did ask if we could have done it for this meeting, but it wasn't convenient with the way things are changed at the moment. But that way they can spend some time looking at how the system works. I think one of your biggest advocates at the moment has been BBC. You can smile and you can nod your head, but a lot of people do not realise the pressure you're under. And to see it there from the phones to the actual delivery of the patient helps the public be far more aware of what's going on. Now, what if somebody over that side had their hand up? And
it was only a very small point, so I was quite happy to let it pass, but no, I've been given the airtime. It was just, I happened to spend a few days in Children's Hospital recently with my son, unfortunately, and it was just how often the ambulances get used for non-emergency services, where it was transporting, in that case, a number of kids had to be transported by ambulance back home at the end of their stay because of broken limbs. And I just was really surprised at the time because they didn't need specialist care. It was literally just transport. I just wasn't sure, and it feels like a small thing. I just wasn't sure how is that. It felt like an unnecessary burden, really, to me on an ambulance service. Is there an alternative?
That is patient transport, which is part of it.
There is, yeah, and I think nationally, MWAS led on a piece of work around what they call IFT, inter-facility transfers. They can make up, along with health professional referrals, 20% of all our activity, enormous. And you're quite right to raise it. What we're aiming to do is re-stratify how those calls come into us. Can they wait longer? Can they go on a different type of transport? Can they be scheduled? Some hospitals even have their own procured transport to deal with that activity. But the more patient services are required at the front end, i.e. in emergency and urgent care for us, whether we're going to triage to provide a solution or respond to a critical incident, those incidents start to tap into that resource that provides that front end. And so the national IFT scheme is looking at how we deal with those type of calls under the ARP, because what happens is they can come through as a red call, they can come through, so whether they come through as a C1 or a C2 or even a C3, they immediately add to our performance. And if we're very busy, when we get to them after 3 hours, as described earlier by the other member, that creates a tail. And clearly, some patients are in a place of safety, but yet they come through into the emergency. So the IFT work is to prevent that happening and stratify that at the front end and see what really needs an ambulance in an emergency or even urgent setting, and can we deal with it differently. Particularly in C3 and 4 categories. There's going to be, again, a piece of work through GM Health and Social Care looking at how we deal with C3 and 4 to distribute that work into the localities and then create an opportunity for the ambulance service to focus on the C1 and C2. And that's an exciting piece of work that's in the ether at the moment. So that should address some of that problem.
Thank you for the explanation.
And it's just a small one, really. I was fascinated to hear that you're now trying to re-divert people who dial 999, but there's judged not really to be necessary to go to hospital, to divert them to primary care. And presumably a lot of your new 2-man vehicles will have to have a clinician on board to be able to make that assessment when they see the patient. And so I'd just like to ask how you're managing with that, and how are you managing also with what you might call not exactly hoax calls, but completely unnecessary calls. People who dial 999 when they've cut a finger, basically, or something like that. And they don't... And they're filtering out unnecessary calls.
Yeah,
yes.
we have we have, through our urgent care desk now, we do look at those and recategorise those calls. So sometimes those calls might spill back to us from 111. And then we will re-triage, and at least between 6.5% and 8% on a good day of those calls we absolutely get rid of altogether with telephone advice, and the recontact rates, so safe disposition, meaning we did the right thing, are minimal, and mean it's a very effective service. But some of those we re-stratify to our urgent care service, so we send a lesser response and keep the emergency side of the service in abeyance. So at one time we used to take all those calls and respond as an emergency, but we are a lot more sophisticated, and on the day visit when you go, you'll see how they actually do that. A very safe system, but one we're trying to develop. And in essence now we're at about 33% of our activity. The aim is to fairly quickly get to about 40% of our activity where we don't provide an emergency response. We provide different types of response.
Pat, thank you very much for that. Some observations back. We know from your presentation what some of the causes are, but it still is a horrifying figure that 85.7% of your responses on that image are outside your own time base. That's a very sad reflection. We appreciate there's a big improvement on what it was, and we hear from what you're saying about how you could continue to improve. That 20% of extra two-ups will make a big difference. We must somehow or other, though, I think that the biggest block to your service is the acute trusts. You've already sorted out the patient transport. It's actually cheaper to send a patient home in a taxi than it is to call NMAS. Salford Royal do that, even with people on Zimmer frames. Go home in a taxi, but with instruction about how to deliver that client, because that's not taking up an ambulance. It shouldn't be happening. By getting the primary care to take some of the load off you, which your telephone service refers back, that's another big improvement. What's that, taking 20% off?
Yeah, and we also have an account for taxis that the urgent care deposit from. So if they speak to a patient who does need to go, whether to a primary care outlet or the acute, but isn't immediately emergency, we can arrange a taxi.
Yeah.
And so we're using that facility more and more as well.
It's faster, it's cost effective. I thank you for your time. I'm sorry if we appear overly critical, but at the end of the day, you've got to admit this thing's needed changing. Thank you very much, guys.
Thank you.
Right, folks, we're 16 minutes overdue now. We've got the workforce, you've got it in your plan there. Sadly, though, or I'm quite glad, I would like to see you all in for extra meetings. We're not going to do it in December, for God's sake. You're all booked up fully now till January. I know your diaries, if anything like most of it is full. But in January, February, we're going to need extra meetings to deal with Theme 3, and I'm sure that you'll manage, even though some of you might not be able to attend, you will do your best. For your time, I'm very grateful. I'm sorry for the overrun. Thank you.
Chair, can we ask for the greatest, we know you would, but can you give us the greatest possible notice of the extra meetings?